My name's Jess. So as mentioned by Dee, I work at IK Concepts with Philip Chang. And I'll just share a little bit about how we've had outcomes with red light therapy in our clinical practice. But I think, probably a good place to start off is just by highlighting that, myopia has really revolutionized what we do as optometrists in our clinical practice. And I think we've all heard those statistics that something like 20 million Australians are going to be myopic by the year 2050. So I think it goes without saying that implementing some sort of myopia control therapy is critical at the moment. The myopia epidemic's not all negative. I think it really does kind of position us in a great place right now to start implementing myopia control therapies. And that's pretty much what I do every day. So a little bit about me. So I graduated back in 2021, started off my clinical career working in a corporate practice, so primarily doing a lot of ortho-K within my first couple of months, and then transitioned into a more pediatric-based clinic where we do pretty much myopia control across the board, and recently incorporating a lot of new novel technologies like red light therapy as well. And so red light's something that we have kind of introduced now since the start of the year. So our longest sort of patient records date back to about 6 months now on red light. We've got about 15 to 16 patients on this form of therapy at the moment. And it's really revolutionized the way that we practice. And I think it's been a really great tool, kind of similar to what Alex was saying in terms of patients who are progressing quite rapidly. And it's shown some really great outcomes. So I'll just kind of walk you through how we do red light therapy in our clinic. So we initially start by obviously identifying the patient at risk. And so typically this tends to be really fast progressors or non-responders. And then after discussing with the patients about the possibility of red light, talking about the pros and cons, getting the consent, we then start the treatment and we kind of strategize how we're going to do that. So particularly important for your patients that are on dual treatments like atropine. Once we've discussed that, we create an iRising account by contacting the great team. They then deliver the machine to the practice and we set up a little bit of a teaching session just to kind of show patients how to use the machine, what to look out for, making sure that everyone's on board. And then once that's done, we, at the same consultation, do baseline scans, so just to make sure that everything is going according to plan. And then we review them in a month, repeat those scans, make sure everything's going well, reiterate some of the things that they should be looking out for. And then we do reviews every 3 months for the first year and then every 6 months thereafter. So just to kind of tie this all into a case example, first patient that I've got is a 9-year-old, very strong family history of myopia, and she presented with very high amounts of myopia as well as some axial length elongation. Like most 9-year-olds, not very compliant with her spectacles, so even though she was technically on the right track, we weren't getting great results. And so immediately this patient was flagged as obviously a high risk and fast progressor. And so we started her off on ortho-K as a way of kind of promoting compliance and getting some sort of control underway. But things didn't work out really smoothly. So she came back to us about a year later, just on monotherapy, still progressing really quickly. And so we decided to start implementing dual therapy. So we put her on the 0.025 atropine. We then lost her a little bit to follow up, but she came back eventually, and we were still seeing continued growth and continued progression. And again, we started to worry at this point because she already is such a high myo. We then hit her with a 0.05 atropine, hope for the best. And then thankfully, we started to get the red light machine into our practice. So at the start of the year, we then chatted to her mum and dad about the proposition for starting red light therapy. And at that point, we started to see excellent results. So I think initially why we were so worried is because she was such a high-risk patient. She was at the point that we had seen her now 13 by 2025, so getting a 13-year-old not to be on their phone or digital devices, lifestyle issues were huge. And we obviously weren't seeing a lot of control with what we were doing. And so red light was really this kind of novel treatment that we could start to introduce that could slide right into what she was already doing and hopefully give us great outcomes. And that's exactly what we saw. So once we started her on therapy, she's now been on the red light and ortho-K for 6 months. And you can see excellent stability to her axial length and even a little bit of a regression. And this was the first point in our whole treatment protocol that we started to see some stability to her outcomes. So really kind of reinforces red light's role in managing more complicated, fast progressing patients. Case study 2, I'll go through very quickly, but it's a similar sort of thing. So again, this is a 7-year-old patient who also had a very high family history, presented with quite a moderate amount of myopia and some axial length elongation. So we started this patient on with ortho-K and atropine straight away. Same sort of issues, unfortunately. We were still seeing really fast progression, so we popped him on 0.03 atropine, not getting the best outcome that we wanted at the time, changed him to 0.05 atropine, still weren't seeing great results, hoped and prayed for a little bit of success with red light. And again, you're dealing with quite a lot of variables with this case. You've exhausted all options already. He started to have a really bad or poor topography result with his ortho-K as well, which was kind of detracting from the efficacy, so we swapped him into MySight. It was a very complicated case, but eventually we had him on MySight plus atropine, and then of course when that wasn't proven to be effective, we started to think about red light. And again, this is his data at the moment, so really good regression, excellent compliance rates, and again, some really good stability being reached with him as well. So hopefully what these cases kind of show is that, you know, myopia management isn't a one-size-fits-all approach, and I think red light really does offer a lot of hope, especially in cases where the traditional methods aren't proving to be completely effective. And it kind of does show, you know, with the technology that we have now, you know, red light really can be a great option to consider. And so finding ways to overcome barriers to access of red light in your practices is quite useful, especially because it can help transition red light from a niche option into something that's actually an evidence-based tool to incorporate into clinical practice. And that can kind of show that, you know, the future of myopia can actually be pretty, literally quite bright, and it can help provide really great outcomes for a lot of patients. And, you know, what you do for your, you know, non-responding patients today can actually change what the generations to come will look like as well. So hopefully this kind of gives you a little bit of insight into how to incorporate red light into your practices and help you out on your journeys as well. Thank you.